Coming to question 41 of our previous year NEET PG question series. This is a 2023 ROMAT question. So it's a big question. Last line is, what is the most likely diagnosis? So you'll try to pick up clues during the question. A chronic alcoholic patient presents with acute pain and swelling of the right great toe. He denies a history of trauma. He gives history of diarrhea for the past 1 week, probably due to outside food intake. Analysis of synovial fluid shows raised leukocytes. Blood investigations are as follows. HB is 13.5, TC is 12,500, platelet 1,89,000, RBS is 107, urea is 37, creatinine is 0.7, SGOT or AST is 104, SGPT is 43, ALP is 178, GGTP is 347, uric acid 3.4. What is the most likely diagnosis? So it's a very big question. There's high chances that we may get disoriented here. So it's an alcoholic. Pain and swelling of right great toe. I think pain and swelling of the right great toe itself is a very important one-liner. So straight away we may take that this is gout. But anyway, try to rule out the other things also. There is no history of trauma and there is history of diarrhea for 1 week. So diarrhea for 1 week means there is something causing dehydration. So that also leads to gout. So dehydration, alcohol, there are 2 triggers for gout. And that's also outside food intake. We don't know what type of food, because high protein diet also leads to gout. Analysis of synovial fluid shows raised leukocytes. This raised leukocytes is a very non-specific finding, because it can occur in gout, it can occur in pseudo-gout, it can also occur in septic arthritis. But septic arthritis, the patient should have very severe fever. He should be immunosuppressed. There should be involvement of only one joint. But a one small joint like the right great toe is very less likely. So always remember, first metatarsophalangeal joint or great toe is invariably gout. Total count is mildly increased. Platelet is normal. Urea creatinine is normal. SGOT is 104. SGPT is 43. Just we'll take a side route and discuss about LFT also here. So OTPT, definitely they are elevated because around 35 is only the normal limit. So SGOT is elevated, SGPT is elevated, but the SGOT by SGPT ratio is more than 2 here, right? This elevated the SGOT, elevated SGPT with SGOT-PT ratio more than 2 means it is alcoholic hepatitis. So in LFT interpretation, we know that we have AST, ALT. AST is also called as SGOT. ALT is also called as SGPT. We have ALP, that is alkaline phosphatase. We have GGTP. If ALP and GGTP are elevated, it is a cholestatic pattern or an obstructive pattern. So in that case, we have to think of a surgical cause. Think of a surgical cause of obstruction, or in medical cases, we have primary biliary cirrhosis and primary sclerosing cholangitis. If AST and ALT is elevated and ALP and GGTP are relatively normal, it is a hepatocellular pattern of LFT. It's a hepatocellular pattern. All the other causes are hepatocellular pattern, like viral hepatitis, autoimmune hepatitis, alcoholic hepatitis, etc. and drug-induced hepatitis, drug-induced liver injury, everything. In alcohol, one peculiar thing is AST, ALT is elevated, GGTP is also elevated. There are some drugs which induce GGTP, alcohol is one among them. So elevated AST, ALT, elevated GGTP is alcoholism. AST, ALT elevated with AST, ALT ratio more than 2 is alcoholism. Okay. Why AST is elevated? Because AST damages the alcohol damages the hepatocytes, and OT is more predominant in hepatocytes. Why ALT is low? ALT needs pyridoxine for its metabolism. Pyridoxine deficiency occurs in alcoholism. That is why ALT is low, AST is high. Uric acid is 3.4. We may think gout is a disease caused by high uric acid deposition in the joints. But here uric acid is 3.4, and we can always guess that normal uric acid level is less than 6 or less than 7. In males it is less than 6, females it's less than 6, males is less than 7. 3.4 is a very normal range. Can gout occur with a normal uric acid? That is our biggest question. The answer is actually yes. Serum uric acid levels does not always correlate with gout. Of course, chronic hyperuricemia is a predisposing factor for gout. That is why high protein intake, etc. leads to gout. But during acute gout, uric acid will be normal because entire uric acid gets deposited in the joint. So serum uric acid will be normal. So don't get misled by the point that serum uric acid is normal here. In acute gout, serum uric acid will be normal. So this is one of the paradoxes in gout. In spite of chronic hyperuricemia leading to gout, during an acute attack of gout, serum uric acid levels will be normal. Another paradox in gout is that during treatment, we have two types of treatment. First thing is, we have NSAIDs, painkillers, and colchicine. Colchicine relieves symptoms. Colchicine has TNF-alpha antagonist effect. It relieves the symptoms. Then we have the preventive treatment. That is either uricosuric drugs which excrete uric acid, or we have drugs which reduce uric acid synthesis. Drugs which inhibit uric acid synthesis are allopurinol, febuxostat. Uricosuric drugs are probenecid, etc. Usually we don't use uricosuric drugs. We usually use drugs with reduced synthesis, because uricosuric drugs sometimes, by causing excretion of uric acid in the kidney, can lead to uric acid stones. There are 4 types of renal stones. One among them is uric acid stones. So to prevent that stones formation, we do not give uricosuric drugs. We commonly give allopurinol or febuxostat. We have another category called as enzymes, that is rasburicase. They are uricase enzymes which break down the uric acid. They are usually used in emergencies. Some conditions where uric acid levels rise very high in emergencies, TLS, tumor lysis syndrome, or hemolysis. Because when the cells lyse, the intracellular uric acid gets released. So in tumor lysis syndrome or in acute hemolysis, maybe you can use rasburicase. Rhabdomyolysis, all the lysis. Rhabdomyolysis. So allopurinol or febuxostat are used. So in spite of these things, during an acute attack of gout, we must not give we must not give allopurinol or febuxostat. Because these drugs, like uricosuric drugs or when antiuricose drugs are given, it causes acute crystallization of the uric acid. So during an acute episode of gout, we are supposed to relieve only the symptoms. Only colchicine, or maybe in severe symptoms, steroids can be used. But we do not give the pathology changing drugs here. Only when the acute episode of gout settles, we are supposed to give uricosuric drugs or anti-uric acid producing drugs. So taking all those things together, an alcoholic with diarrhea outside, right grade 2 pain is gout. So what crystal finding you will get here is needle-shaped crystals. Needle-shaped, negatively birefringent crystals. That will be specific. Leukocyte is a non-specific find. Pseudogout is calcium and phosphate deposition in the joint. Usually occurs in people with hypercalcemia. So here there is no given evidence of hypercalcemia. Seronegative arthritis. Seropositive arthritis is rheumatoid arthritis. Seronegative arthritis we have 4. One is ankylosing spondylitis. Next is psoriatic arthritis. Then we have reactive arthritis. Fourth is IBD related arthritis. IBD is ulcerative colitis or Crohn's disease. So ankylosing spondylitis is an axial seronegative spondyloarthritis. It affects the spine. The psoriatic, reactive and IBD arthritis are appendicular seronegative arthritis. They affect the hand joints or leg joints like that. Psoriatic arthritis, definitely there will be a history of psoriasis or a family history of psoriasis. It commonly affects the distal interphalangeal joints. Rheumatoid arthritis affects the proximal interphalangeal joints. The PNP don't go together. Psoriatic arthritis, proximal interphalangeal joint is not involved, DAP is involved. RA, PAP is involved. Reactive arthritis, again large joints like knees are affected. There will be usually a history of infection recently. One named example for reactive arthritis is the Retter's syndrome or the Retter's triad. Conjunctivitis, urethritis and arthritis. That arthritis is called reactive arthritis. So following an infection of non-gonococcal urethritis, there will be conjunctivitis and arthritis also. IBD I told, ulcerative colitis and Crohn's disease. So there will be bloody diarrhea. In this question also they have given diarrhea. That's why people may get confused with IBD arthritis or seronegative arthritis. But usually in IBD the diarrhea is chronic bloody diarrhea. It won't be just a 5-day diarrhea. Okay. Alright. And septic arthritis, why not septic arthritis? I told patient will be very sick. So that's also less likely. So the answer here is gout.